We're talking today on antidepressants. Let's see there. Interaction between antidepressant drugs and sedation. Welcome. Sedation and depression drugs use their mechanism of action and how they interact with each other. So let's start off with a few definitions. Procedural sedation aims to reduce anxiety and pain during diagnostic and therapeutic procedures while ensuring that the patient remains responsive and able to maintain protective reflexes. Antidepressants work by altering the levels in the brain of serotonin, noradrenaline, and dopamine, which are responsible for regulating mood and emotion. All of that's very conventional. Currently, this definition is contentious, is challenged by the default mode modulation, DMM theory using known antidepressant drugs, so it includes that as before, keto diets. Any one of you understand the importance of keto diets in medicine? Please go and read up. It's really the buzzword these days. Then use of microdosing of drugs like ketamine. All of us are quite aware of ketamine being used in microdoses for people with treatment-resistant depression. Psilocybin, magic mushrooms, ayahuasca, DMT, tryptamine, dimethyltryptamine, LSD, and ecstasy. These drugs are moving into the world of medicine very, very fast. The days that the hippies in the 1960s went on trips, that's past tense. Currently, microdosing of these drugs have tremendous potential of changing the face of medicine, and because that needs to be included in depression, that's why I'm talking about DMM or just mentioning it. Millions of patients are on antidepressants worldwide and get procedures done under sedation and anesthesia, mostly without any adverse events. All of you give sedation to patients on antidepressants. Nothing happens. And that's the danger, because under the surface lurks a lot of problems, and that's what we're going to discuss. Some antidepressants may enhance the effects of sedative medications, enhance effect. Others may decrease the effectiveness in combination and cause severe fallout, and this leads to all sorts of problems. So I'm going to summarize the lecture in one slide. That makes it possible that if I run a little bit over or getting close to the end of time and we can't discuss all of it, that is the lecture. Sedation drugs and antidepressants work synergistically to deepen sedation. Patients on an antidepressant, be careful, do not overdose. Both sets of drugs can prolong QT times. Reinhard's going to talk about QT times, so I'm not going to talk too much about that. 80% of patients on antidepressants that's given sedation drugs have prolonged QT times. You have not noticed because you haven't been looking. Fortunately, it does not cause problems mostly, and only 0.4% develops the early symptoms of torsades, the point. But if they develop that, 2 in 18,000 are fatal. So if you don't look for it, you won't see it. Both sets of drugs can increase risk of serotonin syndrome. Past Congress here, I spoke about serotonin syndrome, so we'll quickly just go through it again. Somebody is agreeing. 14% of patients on antidepressants that you give sedation develops early or mild SS, serotonin syndrome. And you don't see it because you don't look for it. But if it's severe, fortunately it's rare, it can be fatal. Combined SNRIs, serotonin norepinephrine reuptake inhibitors, combined with MAOIs, can interact with sedation drugs by increasing the levels of noradrenaline, hypertensive crisis. You see MAOI, you see trouble. Big marks. I'm going to say that a couple of times during the lecture. Hypertensive crisis, extremely high blood pressure, headaches, death, rare but fatal. Contrary to what most of you sit and think here, ketamine inhibits NMDA receptors targeted by antidepressant medications that can worsen depression directly after the procedure. It's rare, dangerous, known suicides. Be aware, just because ketamine low-dose infusions are used for depression, it does not mean that your patient is always going to be lighter on its depression. They can commit suicide straight after your sedation. 2 of them here in South Africa known. Ketamine increases glutamate release and the activation of the rapamycin-mTOR pathway. It leads to an increase of synaptogenesis and new neural connections, which contribute as part of the theories around how it works to the antidepressant effects, and this is fortunately more common. This is what we all know. You give ketamine low dose to patients, depression is better. This is fortunately what happens in most of the cases, but always remember that there are going to be ones that the depression suddenly goes into full suicidal connections in the brain, and they can commit suicide. Okay, and that's one of the reasons why if you do ketamine infusions, be aware that patient that you do the ketamine infusion for the depression, mostly they're fine and they're better and they're happy and they hug you because they think you're wonderful. They are the ones that's going to commit suicide. Be careful. SSRI agent inhibit the activity of one of the cytochrome enzymes, CYP2D6, which is usually only about 3% of the activity of the cytochrome system, the cytochrome P450 system, but it's important in the breakdown of about 40% of all the drugs that we use. So it's a very important little enzyme. So the SSRIs inhibit the enzyme, raising opioid levels, and opioids also inhibits it and raise the SSRIs. So it works both ways. So be careful when the patient is on a SSRI because your opiates are suddenly going to be very, very potent. Depressed patients on high-dose antidepressants unexpectedly might need higher doses. So we know first-line sedation drugs and antidepressants work synergistically to deepen sedation. But depressed patients on high-dose antidepressants, that's the clue. High-dose antidepressants might need higher doses of sedation agents due to liver enzyme induction, and then you suddenly have a really serious problem because now you've given a lot of these sedation agents, the patient's already on high-dose antidepressants, and the synergistic side effects then becomes a problem. So now, up till now, your patient that was a threatening serotonin syndrome that's only got mild symptoms will have severe. Your patient with a hypertensive crisis might get into trouble. And then in red, the worst danger for sedationists are those taking combination antidepressants, especially if there's an MAOI present. That's the lecture. So let's get into it a little bit more. Neurotransmitters, I'm not going to belabor the point. The only important part is the reuptake, neurotransmitter reuptake pump. That's where all the fun and games are with the antidepressants. They are our, and look how similar they are. I'm not going to belabor this very much, what they exactly do: dopamine, alertness, noradrenaline, concentration, serotonin, satisfaction, and then changed into melatonin, remember from the previous lecture. Then the role of serotonin, I'm just going to lift out mood. It's a neurotransmitter that regulates mood. You feel more focused, emotionally stable, happier, calmer. Interesting thing there is digestion. Serotonin is formed in the brain. It's what I had in my mind. I didn't know that you produce more serotonin in your gut than in your brain. Nausea is triggered when serotonin is released into the gut faster than it can be digested. In that case, serotonin acts more like a hormone than a neurotransmitter. Most drugs used to treat nausea and vomiting target specific serotonin receptors in the brain. And then sleep. Well, we actually work with sleep as far as I know. Together with another neurotransmitter, dopamine plays an important in sleep. You need serotonin to make melatonin. So for those of you that use melatonin as a pre-med, this is where it fits in. Dopamine, we all know Parkinson's, memory problems, ADHD, that's where that fits in, causes blood vessels to relax at low doses and constrict at higher doses. We use that in ICU. Noradrenaline helps to mobilize the brain for fight and flight. I'm not going to concentrate too much on that, we all know it. Toxidromes, associated with sedation drugs in combination with antidepressant drugs, so that's the serotonin syndrome. We've given a lecture on that. Causes, I'm just going to remind you, antidepressants, tramadol, the opiates, migraine drugs, recreational drugs, but interestingly enough, morphine in the normal doses that we use, usually not a problem except in very high doses, and then ecstasy. Symptoms, agitation, bilateral ankle clonus, that's the sign that you look for if you are worried about the patient getting into a worse or more severe serotonin syndrome symptoms. Incidence, 18% of all anesthetics for depressed patients. Treatment, usually settle quickly in sedation, settling without treatment if you withdraw your serotonergic drugs. If not, midazolam, 1 to 2 milligram doses every 5 minutes, up to a maximum of about 5 milligrams. In higher doses, 15 milligrams, it increases the serotonin levels in the brain. Morphine, 2 milligram titrations every 15 minutes. Small doses of propofol can help. If the patient not compos mentis and still has fever and hyperreflexia after an hour, ICU and treat, even ventilate. Then his lecture on QT times, corrected QT times. Normal is 40 milliseconds. There's a nice formula how to do it, but your ECG machine will usually warn you. Sudden severe ventricular tachycardia. Usually reverts spontaneously, but if you don't revert, it could be fatal. Causes, antidepressants, propofol, ketamine, opioids, and then a long list of other things. Your treatment, if the patient is hemodynamically unstable, I'll leave that to him to look. Magnesium, be careful with any stimulants, and then if you have nothing else, a bit of lignocaine. Hypertensive crisis, we all know the story very well. BP diastolic 120 plus. Do not drop it very fast. They tend to get really in trouble with that. Then esmolol is supposed to be, but it's very difficult to get hold of at the moment. And in that case, you can use labetalol. And there you have the doses. Then opioid-associated respiration suppression. Now, we are now antidepressant plus opioid. That's where we are. SSRI agents inhibit the activity, and there we are back with that enzyme, and the vice versa thing. Careful with patients on antidepressants with opioids. Very careful. Small doses. Prof's idea, or his teaching, that you use small doses and you can always give a little more instead of one big dose. What should you do if the patient, short-acting versus long-acting? Short-acting and obviously much safer. But if you give Narcan, what do you use for the pain control? So if you started off with a short-acting, you waited a little bit, supported the patient, you're probably out of the trouble very quickly. If you use the long one, you're in trouble. Do not just give oxygen supplementation and forget about the hypercarbia. A little sedation tip, start considering oxygen supplementation for any ASA 1 and 2 patient under sedation as an emergency treatment and needed only because of inadequate sedation technique and that inappropriate oxygen use causes hypercarbia. And see your quality of sedation immediately improve. I've seen this literally with the people that come to me for their little training sessions. And the first thing they do, they don't even look for the suction. The first thing they do is the oxygen nasal cannula or whatever. And I say, what are you doing? What are you doing? I'm not going to go through this table, it's going to take too long, but you've got it there. The classic toxidromes. Now, this is where it gets a bit more interesting. Selective serotonin reuptake inhibitors. Most prescribed antidepressants, they increase serotonin, typical is fluoxetine, sertraline, paroxetine. That gives interactions with benzos, propofol, synergistic effects, we've discussed that, respiratory depression, serotonin syndrome. Ketamine antagonizes the effects of SSRIs by blocking the NMDA receptors. This can lead to a decrease in the antidepressant effects, worsen depression symptoms in some patients. This always happens, but is usually balanced by the opposite effect as described above. And the reason why I mention this again is because people don't think about the fact that ketamine can actually worsen the depression for a short while. Opioids can also affect the metabolism of SSRIs by inhibiting the metabolism. This can lead to increased levels of SSRIs and opioids, and I have mentioned that before. Then the serotonin norepinephrine reuptake inhibitors, they're a little bit more dangerous than the SSRIs, so focus a little bit more on them, and the reason why is that they increase the levels of serotonin, norepinephrine, and dopamine, all three. If they increase serotonin, we've got serotonin, norepinephrine, hypertensive crisis. You can have SNRIs giving you a lot of problems with nausea and vomiting, arrhythmias, and you can have acute cardiac failure. Then the NDRIs, only Wellbutrin, and you could treat that as a SNRI when you are looking at side effects. Then the older drugs, the TCAs, tricyclic antidepressants, it's making quite a comeback in prescription by psychiatrists, so be aware. But the TCAs have got a wider side effect profile than the more modern drugs, so be very careful. They can enhance the sedative effects of benzos. They can also enhance the effects, the benzos can enhance the effects of the TCAs with increased sedation and toxicity. And remember that TCAs enhance anticholinergic effects of atropine, scopolamine, that sort of thing. Now we get to the real naughty one. Parnate, Nadal, Eldepril. Irreversibly inhibit monoamine oxidase A and B. So now you've got all three, your neurotransmitters suddenly very high. During anesthesia and sedation, the incidence of mild to severe interaction in 6% of cases, fatalities as high as 0.2%. In some of the studies, that's shockingly high. Aurorix reversible inhibits the MOIs. They say it's safer. I'm not so sure of it, because if you look at the profiles of adverse events, it doesn't look like really much difference. It's particularly high side effect profile when it's combined with the newer drugs. These patients should be discussed with their psychiatrist. If you have a patient that you need to give a sedation, and it's on and the patient is on combined drugs, including a MAOI, phone the psychiatrist. Ask him if you can stop the MAOI for 2 weeks prior to the sedation. That's how serious it is. Sedationists should specifically ask for the use of MAOIs in patients on antidepressants, as these drugs are the most commonly reported drugs in antidepressant sedation treatment, adverse events, and fatalities. Benzos, you've all seen them. The patient comes in and he's on a list of antidepressants and a benzo. They can enhance the sedative effects of the antidepressants. They inhibit the metabolism of TCAs. That's why one of the reasons why the psychiatrists prescribe these drugs is that it makes the antidepressants work more potent. MAOIs inhibit the breakdown of neurotransmitters in the brain and benzos and can enhance the effects. And then we've got the serotonin syndrome and the hypertensive crisis all again. Avoid the use of midazolam in patients already on long-term benzos. And remember, diazepam has a half-life of 2 to 3 days. Ketamine as an antidepressant. Prof. Doe talked about it. I'll just quickly scan through that. Ketamine has been shown to have a rapid-acting antidepressant effect on the majority of individuals with treatment-resistant depression. The other sentence I've already mentioned. MAOIs interact with ketamine and increase the risk of side effects such as high blood pressure and serotonin syndrome. Fortunately, the ketamine dose that we should be using in quite low doses gives less side effects. But this is in red. Patients on ketamine, this is something new because patients are on antidepressant treatment via ketamine infusions. So if they are on a ketamine infusion for the correct reason, treatment-resistant depression, patients on ketamine antidepressant treatments are per definition already on maximum treatment for treatment-resistant depression, and therefore they are an absolute minefield for the sedationist. Be aware. Then the thing that Prof mentioned, the FDA approved esketamine for actual physical treatment of treatment-resistant depression only under direct personal patient to medical doctor supervision for the full duration of every treatment session. That way you keep yourself out of trouble. And it's also a good idea to protect yourself from legal fallout by initiating treatment only under the supervision of a psychiatrist. It's so easy to do. You know, we've got a sister, theater sister, in Johannesburg that gives patients ketamine drips in her garage. Oh yes, and then there's the guy that does it as part of his steroid treatment in the gym. You can build muscles faster if you are not depressed. I don't know, something. Then opioids. We say they can suffer severe respiratory depression. Directly post-op on your depressed patient that received opioids will often be a bit manic. You might remember about 30, 40 years ago, I'm giving my age away now, patients with suicidal ideation. They were given opioids to break that ideation. Not a very wise decision on the long term. Opioids interfere with antidepressant drugs by reducing the availability of serotonin in the brain. So although you break this suicidal ideation for a short while, hours, on the long term, it's more difficult to treat that patient. So the patients that had opioids because of their suicidal ideation often ended up with electrical treatment, shocks for their brain, because they were then impossible to treat with drugs. And that's why they stopped it. It has implications for you, for your post-op pain treatment and addiction issues. So if you've got a patient on antidepressants and you've given an opiate during your sedation, your patient will have problems with the control of the depression. Now, I don't think that L-fentanyl or rapifene will have any effect like that, or very little. But if you use strong opiates for a prolonged period of time and you prescribe post-op opiates, you will make that poor patient's depression worse. Sedation tip. Try to use short-acting opioids during sedation and try to stay opioid-free in your post-op scripts. This is now for the patients on antidepressants. Good. I conclude with that, and we've got quite a lot of resources if you need.
Thank you very much.